Hello everyone. So what are we going to discuss in this particular module? In this module, we are going to discuss regarding two entities. Okay, two very important entities. Let's see what are they. Number one, we are going to discuss regarding rapidly progressive glomerulonephritis, which is abbreviated as RPGN. Okay, and then regarding a very related entity, that is Goodpe syndrome. Okay, Goodpe syndrome. So we are going to discuss regarding these two entities. We'll start off our discussion with RPGN, and then we'll bring Goodpe syndrome also into the picture, and we'll see how much they are actually closely related. All right. Okay. So let's begin the discussion with RPGN. So let's see this term first of all, rapidly progressive glomerulonephritis. So what impression does this term give you? It tells you that yes, this is a glomerulonephritis, but this is a glomerulonephritis which is quite special because of its rapidity. It's a rapidly progressive glomerulonephritis. So in fact, if you are asked regarding what is a RPGN, please understand that this is a rapid deterioration, rapid deterioration in renal function, that occurs over weeks. So there is a rapid deterioration and that occurs just over a few weeks. And this is because of what? This is because of a glomerular affection. So why have I specifically said it is because of a glomerular affection? Because see, you have another term which is again looking very much similar to this, that is RPRF, which is nothing but a rapidly progressive renal failure. So when you say rapidly progressive renal failure, it's nothing but again a rapid deterioration of renal function over a few weeks. But the difference is that that could be because of any cause. It could be because of a problem in the glomerulus. It could be because of a problem in the tubules and interstitium. It could be because of a problem in the vascular supply to the kidney. So that is what you call, the general term is the RPRF, and specifically a glomerular affection is the RPGN. Okay, so I hope you are very clear with this entity of RPGN. Okay, all right. Now, next point that I want you all to understand is RPGN is not a single disease. Okay, it's not like studying a single disease. This is in fact a syndrome. Okay, this is in fact a syndrome. Syndrome of what? See, by syndrome I mean RPGN is just a syndrome where somebody is having a rapid progression of renal dysfunction because of, say, a glomerular involvement. Okay, so it could be because of varied etiologies. There are lots of etiologies for this RPGN, okay, which we will be learning. But understand that everything together is actually called RPGN. It's not a specific disease. It has certain etiologies which we will come to discuss very soon. Okay, so please understand that this is actually a syndrome. Very clear. Okay, let's move ahead. So to understand what are the etiologies falling under the RPGN, we should now classify RPGN. Okay, so how are we going to classify RPGN? Okay, let's look at the types of RPGN, the types of rapidly progressive glomerulonephritis. See, RPGN predominantly has three types. Okay, you have predominantly three types: type 1, type 2, type 3. So though predominantly three types, there is also a fourth type. Okay, there is also a fourth type, but the first three are the ones most important. Now, what is this particular classification? Let's see that. See, type 1 RPGN occurs because of an anti-GBM disease. Anti-GBM disease, which means there is some antibody against the glomerular basement membrane. Okay, that is what happens in type 1. And the prototype of a type 1 RPGN is a Goodpe disease. Okay, all right. Now coming to type 2 RPGN. Type 2 RPGN occurs because of immune complexes. Okay, so remember the type 1 was regarding a specific antibody like anti-GBM, and this one is related to an immune complex deposition. Okay, so it is related to an immune complex deposition. So that again can occur because of various conditions. You can say SLE. Okay, SLE is one. Infection related glomerulonephritis, that is again type 2. Clear? Now when it comes to type 3 is mainly because of type 3 RPGN occurs because it is actually a pauci-immune one. Okay, it is a pauci-immune one. Okay, and hearing this word pauci-immune, if you have listened to my rheumatology module, what is the one that comes to your mind? The ANCA associated vasculitis. Okay, the ANCA associated vasculitis producing a renal problem, that is what is your type 3 RPGN. Okay, then what is this type 4 RPGN? Type 4 RPGN, one term that you have got to remember about your type 4 is double positivity. Okay, double positivity. Now what is this double positivity? Double positivity means it is a particular RPGN where you will have, so double positive means two things are positive. What are the two things? One is going to be a anti-GBM. So the individual is having a antibody against the glomerular basement membrane. So that is positive. Plus the ANCA is also positive. So that is what you call the type 4 RPGN. Okay. So this is how you will classify RPGN: type 1, type 2, type 3 and type 4. Okay. Now in this particular module, our discussion will be mainly regarding the type 1 RPGN. Okay, regarding type 1 RPGN. Now when I am going to discuss regarding type 1 RPGN, before we proceed to the discussion, let me make clear one more point. All these 4 types, okay, irrespective of etiology, okay, all these 4 types have something in common. Okay, so they are all RPGNs, correct? No? So they have something in common, and what is that binds them is that histopathologically they are all characterized by the formation of crescents. They are characterized by the formation of crescents. Now what is this crescents here? It is actually a pathological terminology that in case of all these RPGN, you will have proliferation of the epithelial cells of Bowman's capsule, okay, plus there will be an infiltration by monocytes and macrophages. So both of these occurs, and this results in the formation of crescents. And do you want to see a picture of crescents to make things clear? Yes. So I'll just show you a picture I've taken from Robbins. You can see the 2 glomeruli here, okay, and you can very well see that, I'll just tell you one example. You see here, suppose if I am taking into account this particular glomerulus, okay, are you able to see that there is lot of, there is actually not lot of, there is actually a glomerular structure here. Yes. And are you able to see that just outside this glomerulus, there is lot of, the proliferation happening around here, okay, which I'll just highlight for you. Yes. So there is some proliferation happening here. So, which is not usually found in a normal glomerulus, because see, we have already seen lots of images of a light microscopy finding in the normal glomerulus as well as abnormal conditions. But we have never seen something like this where there is lot of proliferation happening, but it is not within the glomerulus per se. So basically what happens is the proliferation occurs in the epithelial cells of the Momans capsule. So you can also say that this is extra capillary proliferation. Remember, we use the terms endocapillary proliferation, okay, in our previous discussions, but this is a extra capillary proliferation, all right. And the extra capillary proliferation will be such a way that whatever, the infiltrates have been formed there by these cells, the inflammatory cells, it's as if, they are actually pressing onto the glomerulus. And you can see that it is almost shaped like a crescent. Okay, it is almost shaped like a crescent, no? So you can see it's almost the shape like a crescent. Okay, so whatever proliferation you are seeing here, okay, so that is what you call a crescentic glomerulonephritis. So the point I want to tell you, this is the same thing that you can see here also. Okay, there is a crescent formation. So histopathologically, RPGN also has another terminology, and what will be that terminology? Crescentic glomerulonephritis. It is also known as crescentic glomerulonephritis. Crescentic glomerulonephritis. Okay, it is another name for RPGN, crescentic glomerulonephritis. The presence of crescents are there in your RPGN, whatever it be, all the RPGN. Okay, all right. So now we are going to discuss regarding mainly the type 1 RPGN, because the others like say SLE, we have IRGN, we have had separate discussions. ANCA associated vasculitis I have discussed in the rheumatology module. Okay, so we will limit our discussion to the type 1. Okay, now before I discuss this type 1, I will introduce certain terminologies for you, which are which you are likely to get confused with. So we want to clear that straight away and then proceed to good pasture. So these are the terminologies that I want you to know. First terminology that I want you to know is pulmonary renal syndrome. Pulmonary renal syndrome, that is number 1. Okay, all right. Next entity that you should know, that is, remember we are discussing regarding certain terminologies which you should be very thorough of. Okay, because in the question also, when a terminology comes, you should not get confused. Okay, so first is the pulmonary renal syndrome. Okay, second is Goodpe syndrome. Goodpe syndrome. The third one is anti-GBM disease. Anti-GBM disease. And the fourth terminology is Goodpe disease. Goodpe disease. Now these four are terminologies which are related, but again slightly different. Let me make things clear for you. See, the first terminology, pulmonary renal syndrome, it just means that an individual has got an involvement of his kidneys as well as lungs. Okay, he has got an involvement of kidneys as well as lungs, probably as a sequelae to a disease process. Okay, for example, you imagine somebody has got an acute kidney injury. Okay, whatever be the cause, somebody has got an acute kidney injury, and as a result of that, suppose he has got a fluid overload. He has got a fluid overload. So what will happen is that in this particular individual, because of the fluid overload, there will be an increase in the fluid content intravascularly. So there is a chance that the preload is high, you can have a pulmonary edema. So the same patient is having an acute kidney injury, and as sequelae to that, he is developing pulmonary edema. So this is a condition where you are having a pulmonary renal syndrome. It just means that an individual has got a renal involvement and pulmonary involvement because of a particular etiology, whatever it be. Okay, so that is what is called a pulmonary renal syndrome. Okay, now second term you have is the Goodpe syndrome. Okay, Goodpe syndrome. Now Goodpe syndrome means a particular individual is again having a renal involvement and a pulmonary involvement, but here it is more specific. That is, an individual is having an RPGN, that is a rapidly progressive glomerulonephritis, okay, plus he is also having, in addition to the RPGN, he is also having alveolar hemorrhage. That is, in your pulmonary alveoli, there is a diffuse alveolar hemorrhage happening. So that is what you call a Goodpe syndrome. Remember, I said syndrome and not disease. The third one, the third entity is Goodpe is anti-GBM disease, where, see, an individual has got, okay, so remember anti-GBM disease. So he has got RPGN, okay, and diffuse alveolar hemorrhage, but it is because of some antibodies to the antibodies against glomerular basement membrane. It is because of some antibody against glomerular basement membrane. They are not specifying the name of any antibody because there are lots of antigens that can occur in the glomerular basement membrane. So against any of the antigens, if you have an antibody production and subsequent RPGN and an alveolar hemorrhage, that is what you call an anti-GBM disease. Now what is a Goodpe disease? A Goodpe disease means again an RPGN plus alveolar hemorrhage, okay, same like an anti-GBM disease, but the only thing is that you will call something as a Goodpe disease only when you have a specific antibody. Which antibody? You have an antibody against alpha 3 chain of the non-collagenous domain of type 4 collagen. Okay, type 4 collagen. So type 4 collagen, you will have a non-collagenous domain, and specifically if you have antibody against the alpha 3 chain, okay, against the alpha 3 chain, that specific antibody resulting in an RPGN plus a diffuse alveolar hemorrhage, that is what you call a Goodpe disease. That is what you call a Goodpe disease. So these terminologies should be very clear to you, because I'll tell you what will happen if you confuse a Goodpe syndrome with a Goodpe disease. Because let me show you the list of conditions. Okay, so these are the conditions, the list of conditions which can produce a rapidly progressive glomerulonephritis plus a lung hemorrhage. So when you have an RPGN plus a pulmonary the alveolar hemorrhage, that is equal to what? That is equal to Goodpe syndrome, the GP syndrome. Okay. Now you see the etiologies for a Goodpe syndrome. See, 20 to 40% cases is occurring because of antibodies against the glomerular basement membrane, which is predominantly your Goodpe disease. But you see there are lots of other systemic vasculitis which can produce a rapidly progressive glomerulonephritis as well as a alveolar hemorrhage, like your microscopic polyangiitis, your Wegener's granulomatosis, SLE, Churg-Strauss, HSP. So all these conditions can also produce what? Goodpaster's syndrome or disease? Syndrome. Okay, that is important, because if you do not understand that, you will just think that okay, Goodpaster's syndrome equal to Goodpaster's disease. No, they are not the same. This is the difference. So I hope that is very clear to you. Now we are going to learn regarding Goodpasture disease. Okay, Goodpasture disease, because we have seen a list of conditions which can produce a Goodpasture syndrome. So now we are going to discuss regarding Goodpasture disease. Goodpasture disease. So this disease, Goodpasture disease, yes, it is an autoimmune condition. It is an autoimmune condition, and this autoimmune condition is characterized by IgG antibodies. IgG antibodies. IgG antibodies against what? Against IgG antibodies against alpha 3 chain of non-collagenous domain of type 4 collagen. Type 4 collagen. And remember that this entity of Goodpaster's disease is a classical example of a type 2 hypersensitivity. It is a classical example of type 2 hypersensitivity. Okay, so that is what is this disorder. And you see, what is the peculiarity of this antibody is that, see, type 4 collagen is a component of basement membrane at different sites. But when it comes to the alpha 3 chain, okay, the alpha 3 chain, there are very limited locations where you will find this alpha 3 chain, and the predominant areas where you will have this in the basement membrane. We are talking of the basement membrane. One is in the glomerular basement membrane, okay, and second is in the alveolar, in the lung alveoli, the alveolar basement membrane as well. Okay, so both these sites will be having the alpha 3 chain. So when somebody has an antibody, it is likely to produce a pulmonary renal syndrome. Okay, because Goodpasture disease is also a pulmonary renal syndrome where you can have a renal affection as well as a pulmonary affection. Okay, so I hope you understood, about the antibody. Now about the age group of presentation. See, this is actually having a bimodal age distribution. Okay, Goodpasture disease is having a bimodal age distribution. So bimodal age distribution, first of all, you will have a peak in the 20 to 30 years age group. Okay, 20 to 30 years age group, where it will be predominantly found in males. Okay, 20 to 30 years age group where it will be predominantly found in males. And then you will have the 60 to 70 years. Okay, 60 to 70 years. Even beyond that, beyond 70 years also it can occur. So there, it will be found more like in both males and females. Okay, males and females. Okay, males and females. All right. Okay, now what happens is, I already told you, there is some production of antibodies. But please understand that there are certain precipitating factors for this disease to manifest. Okay, so or some important triggering factors, you can say, triggering factors. That is, see, patients with a Goodpasture disease, I told you they are having antibody, but often the clinical manifestation is triggered in certain individuals. That is, one is smokers. One is smokers. Second is those with hydrocarbon exposure. Hydrocarbon exposure. Third is in those who are having some pulmonary infection. Pulmonary infection. And also in those with fluid overload. In those with fluid overload. So these are some of the triggering factors that can, which causes a manifestation of a Goodpasture disease. It is not that they are primarily responsible for production of a Goodpasture disease. They are actually triggering agents. Okay, triggering agents for a clinical presentation. Most often you will have a smoker presenting with a manifestation of Goodpasture disease. Okay, so I hope that is clear. Now coming to the clinical manifestations. Okay, having understood what happens in the Goodpasture's disease, let us move on to the clinical manifestations. Okay, so clinical manifestations. Clinical manifestations. So clinical manifestations, as is quite obvious, you will have a pulmonary renal syndrome. Okay, you will have a pulmonary renal syndrome. And remember, I told you there is a bimodal age group. The younger individuals, okay, in the 20s, they are the ones who are more likely to have a lung plus renal involvement. Okay, so those in their 20s, okay, those in their 20s are likely to have pulmonary plus renal involvement. But when it comes to those in the 60s, okay, those in the 60s, it is more a renal presentation. It is more a renal presentation because I told you that when it comes to the Goodpasture disease, yes, you can have a combination, but sometimes you can have the same disease producing only a renal manifestation. Okay, that often occurs in the elderly age group. Okay, where you can have a renal presentation alone. Now, see, we are discussing this under the renal RPGN, which is which is why this presentation of this Goodpasture is mostly as a RPGN, rapidly progressive glomerulonephritis. So the deterioration of renal function will occur over weeks. Yes, you will have a nephritic type of presentation. Okay, it is in fact a nephritic type of presentation. You will have hematuria, you will have oliguria, there will be RBC cast in the urine, there will be edema, proteinuria which is not in the nephrotic range, okay, but still you will have a mild to moderate proteinuria. So a nephritic picture will be there, but the only difference is that it is more rapidly progressive. So the clinical presentation, I would like to use the term RPGN for the renal involvement. Okay, sometimes he might totally have anuria as well, total renal shutdown also. Okay, that is what happens in RPGN. Okay, that is the renal presentation of Goodpasture syndrome, Goodpasture's disease. But when it comes to the pulmonary involvement, see, you can have cough, and because of the alveolar hemorrhage and because the blood is actually there in your air spaces, it can be coughed out and you can have hemoptysis. Okay, cough and hemoptysis will be there. Okay, so I'll just show you X-ray of a individual. You see here, you see there are two X-rays here. So the first X-ray and second X-ray are of the same individual, a patient with Goodpasture disease developed hemoptysis. This is the first X-ray. It looks relatively normal. The second X-ray was taken after 4 days, and the second X-ray you can definitely see that you are having obvious signs. The first X-ray actually looked very much normal, but in the second X-ray you are able to see all these infiltrates which have occurred because of the alveolar hemorrhage. Okay, so just wanted to tell you that sometimes an initial X-ray of a Goodpasture disease can be deceiving. Okay, so you have got to keep that in mind, and it is always important to have a good clinical suspicion so as to link a renal and as well as a pulmonary presentation, because sometimes for an individual who is having a renal problem or a renal shutdown, if you find that he is having some shadows in the X-ray, you might initially think this might be some pneumonia. Okay, so there is always a chance that you might miss unless he presents a florid manifestation. So if somebody presents with a severe hemoptysis and then oliguric renal failure, then probably the diagnosis becomes more clear. But otherwise, this disease can sometimes trick you, and you have got to have a high index of suspicion. Okay, all right. So that's it about the clinical presentation. We have understood the age group of presentation. We have understood it presents with a pulmonary renal involvement, and in elderly you may have a isolated renal involvement also. So that is very clear. So when it comes to investigations, okay, when it comes to investigations, in case of a Goodpe disease, see, something that is quite obvious is for the pulmonary manifestations, yes, you will have to do a chest X-ray. Okay, you will have to do a chest X-ray. Sometimes you will have to go for a HRCT thorax also. Okay, HRCT thorax. Okay, and another, something that else that you can do is that in the pulmonary function test, okay, you can look for the DLCO, and what will happen to the DLCO in case of a pulmonary hemorrhage. You should go back and watch my pulmonology module where I have clearly told you there is an increase in DLCO in case of your pulmonary hemorrhage, that is your alveolar hemorrhage. Okay, so you will see an increase in the diffusion capacity of your carbon monoxide. That is because of this carbon monoxide, going and binding to the hemoglobin. There is a high affinity and you will have the hemorrhage into the alveoli. Increased DLCO, very, very important. And also your sputum, when you do the sputum examination, you will be able to demonstrate hemosiderin-laden macrophages. Hemosiderin-laden macrophages. Okay, hemosiderin-laden macrophages. Okay, and what about the renal? Definitely you will have to do a urine examination. Okay, you will have to do a urine examination. In fact, the basic workup of any nephritis you have got to do, and you will be able to see the RBCs, RBC cast, proteinuria will be there. So the basic workup of a nephritis you have got to do. So what else will you do? In the renal workup, what else will you do? Do you need a biopsy? Yes, you will need a biopsy. You will need a biopsy. Okay. So in biopsy, what are the findings that we are going to see? Remember, like in the other conditions we learned, we have got to see what is there in the light microscopy. Okay, light microscopy, the immunofluorescence, as well as electron microscopy. Let's see what happens. See, often in light microscopy, what you might see is that you will have, if it is a RPGN, I have already shown you a light microscopy picture of a RPGN, where you will have what? Crescent formation. You will have crescent formation, and I have already told you why the crescents occur. So that is what you will look for in case of a light microscopy. Now what about immunofluorescence? Very, very important. See, in immunofluorescence, the finding that you are going to see, which is very important, when this Goodpe disease is asked as a clinical scenario, they are likely to put this among the question that the immunofluorescence shows this particular finding. It's a very unique finding which you have not learned with other glomerular disorders in the various modules that I have taught you. That is, there is a linear IgG and C3 deposition. Okay, so there's a linear pattern of deposition. The key word is linear. Okay, because in various other glomerular disorders you would have read regarding granular pattern of deposition. So this is actually a linear pattern of IgG and C3 deposition along the basement membrane. Okay, so why is it linear? Because all these pathogenic antibodies are specifically against a component of the basement membrane. So you will have all these linear IgG and C3 deposition along the basement membrane. Very, very clear. Okay, and just to show you, even in the immunofluorescence also, can you tell me what is this? What are these arrows pointing to? What are these arrows pointing to? Well, it is in fact the crescents they are pointing to. Okay, the rest of the glomerulus you can see it is taking the bright color, but the remaining part you can see this is actually the crescents. Okay, the crescents, the area of the crescents which I'll just highlight for you, okay, the area of the crescents, okay. So it is just that, or you have the proliferation of these the epithelial cells and subsequent compression of the glomeruli. That is what you are going to see, okay. All right, so you will see the crescents also. And then when it comes to electron microscopy, see, what are you going to see in your electron microscopy is that, I'll just show you a picture, okay, another picture from Robbins. So here what you are seeing is that, are you able to see the basement membrane here? Yes, you are able to see the glomerular basement membrane. So there are two findings that you will look for. One is the wrinkling of the basement membrane, wrinkling of the basement membrane. The second finding that you will have is you will have focal disruptions of the basement membrane. You will have focal disruptions of the basement membrane. So you can see that the arrows are pointing to the disruptions in the area of the basement membrane, okay. So that is what you get in case of electron microscopy. So I hope you are very clear with the light microscopy findings, immunofluorescence and electron microscopy findings. Light microscopy, remember, you will have crescents, but see, not just crescents, maybe as the disease advances, you will also see areas of necrosis in the glomeruli. You will have areas of glomerular sclerosis. You will have areas of glomerular sclerosis, okay. So these all also can be found in case of the light microscopy. So I hope you are very clear with the biopsy findings in case of Goodpe disease, okay. All right. Now I'll just show you a lung biopsy finding. This is an open lung biopsy finding where you can see inside these alveoli, you can see lots of hemorrhage happening, okay, lots of hemorrhage happening. So that is it, okay, that is it regarding the biopsy findings. So far I hope you have understood regarding the, about the clinical presentation, how rapid is the presentation, okay, and how the disease actually progresses also. Yes, the disease actually can progress to develop a chronic kidney disease also, okay. All right, so this is not a disease with a great prognosis. You have got to intervene early. Let me tell you, early intervention is very, very important. So let's have a few words regarding the treatment of Goodpe disease as well. See, Goodpe disease has to be managed very aggressively. So how do you manage this? You will go for plasma exchange. Why are you going for plasma exchange? Because you want to remove these antibodies. That is the antibodies in a Goodpe syndrome. You want to remove it from the circulation. And remember, it's not plasma exchange alone. It is plasma exchange in conjunction with steroids plus cyclophosphamide. So you have got to give a pharmacotherapy also, okay, plasma exchange in conjunction with steroids and cyclophosphamide. That is how you will aggressively treat a case of Goodpe disease. Now, certain pointers you should know is that when you decide to treat a patient with Goodpe disease, there are certain indicators or certain patients where you should definitely go for an aggressive management. And there is another group of patients which you are almost sure that even if you go for an aggressive management, you are not likely to get much benefit. So just let's have a look at this particular table on the factors favoring an aggressive treatment. That is, an aggressive treatment is likely to offer some benefit. One is if the pulmonary hemorrhage is there. Okay, I'm saying if the pulmonary hemorrhage is there, you know, when you institute treatment, it is more likely that the individual is to respond. Okay, so you have got to keep in mind that point, pulmonary hemorrhage. But on the contrary, if you have oliguria, okay, it is not at all a good sign. So if there is no oliguria, okay, if the patient has not gone for an oliguria, you know, it is urine output less than 400 ml. So if the patient has not developed an oliguria, it is a good sign for a aggressive treatment with plasma exchange plus steroids and cyclophosphamide. And also if the creatinine is less than 5.5, okay. So if the creatinine is very high, then you know it is again an indicator that you are not going to get much benefit. But there are certain exceptions, okay, that is, even if the creatinine is above 5.5, there are certain scenarios in which you are likely to get a benefit. And one of this is the creatinine is more than 5.5, but there is a rapid and recent progression, which means that this might be the first presentation of the patient. You can have another patient where he has already had, say, 3-4 presentations, okay. But if it is a new onset and the first presentation, it is always, likely that he might respond if you treat it aggressively and early. And this is one very interesting point I want you all to understand. You remember I told you something about when we discussed RPGN, I told you type 4 RPGN, where you have the double positivity. So individuals with double positivity, that is, you have antibodies against the glomerular basement membrane, okay, against the alpha 3 chain. Along with that, you're also having ANCAP positivity. See, if you are asked to guess 2 antibodies together positive, what about the prognosis? You are likely to guess that prognosis will be poor, but it's the contrary, that if you have an ANCAP positivity, there is a more likelihood chance to respond and it is having a slightly better prognosis, okay. And when you do a biopsy, if there are no significant glomerular damage, because you are looking at the biopsy, you have a few crescents here and there, but it is not so diffuse in all the glomeruli, then there is a better chance. And when the crescents are recent, because what happens is, if there has been a considerable progression of the disease, along with the crescents, you will see lots of fibrosis also. But if you do not see fibrosis in the renal biopsy, it is again a good sign that the patient might respond. And also, if you are planning for a renal transplantation also, you should go for a aggressive treatment. This again is important. I would again stress on this ANCAP positive double positivity, because that is also specifically mentioned in Harrison. So the examiner is likely to test your knowledge on that. Okay, so I hope this part is clear. So just to summarize, see, we have discussed RPGN and glomerulonephritis together the Goodpe disease together in one module. So I am sure you have understood why I have discussed, because see, Goodpe is a prototype of type 1 RPGN, and the remaining RPGN we have discussed in various other modules, okay, some in rheumatology, some in nephrology itself. So it means that overall this is a very important disease, Goodpe disease. Often questions are asked, it is very easy to frame a clinical question based on this, so you must learn this very well. The problem with Goodpe disease is, see, once it has presented, the aggressiveness of the course, the disease course, that is what troubles us. See, if it was some disease with a slow progression, then with plasma exchange, steroid, cyclophosphamide, it would have had a wonderful prognosis. But because of the rapidity, and probably by the time the patient reports to you, he might have already had a significant glomerular damage, lots of crescents in his renal glomeruli. So then that would have caused more problems, okay. So then that means, even if you institute the treatment, you are not likely to get the patient back. He might actually develop some life-threatening hemoptysis, or maybe he might develop a renal failure and associated complications, and he might die, okay. So see, when I talk about death, it can be because of any of the sequelae as a result of the renal injury. It might be a hyperkalemia, patient developing a renal failure, developing a hyperkalemia and a sudden cardiac arrest. So any of these complications actually can happen in Goodpe disease. So it is very important to learn this entity, and I hope you have conceptually understood, okay. That is more important, to understand the topic. Then you feel that once you have listened to the module, you will get a feeling that, okay, I have understood this. So that maybe here and there, even if you forget a few factual points, when it comes to the exam, when you see the question, you will be able to recollect the scenario. Always remember, when you learn, you've got to think with a patient perspective, like how the patient is going to present. You imagine, either from your own experiences, if you have seen a patient with Goodpe, or just think, how is a patient going to present? A patient presenting to the medicine department or nephrology department with a nephritic presentation. but a more rapid course, and suddenly he coughs out blood, hemoptysis, then it should strike you. Could this be a Goodpe disease? Okay, so it's important to link both. You cannot dissociate the pulmonary symptom and renal symptom, which is why, suppose you are doing MD medicine, you have done your MD medicine, and suppose you have become a whatever, maybe a endocrinologist or nephrologist or whatever it is. It is always important that you have medicine also with you, because otherwise you will not be able to link. Okay, because suppose you are a nephrologist, you have got to have a clear idea regarding what happens to the lungs also. Okay, otherwise you will not even bother to take a chest x-ray in a patient with a rapidly progressive glomerulonephritis. Only if you have certain conditions in your mind, you will take a chest x-ray in that patient. So it is very important. And remember, I told you, even chest x-ray in the early stages can be deceiving. So hemoptysis along with a renal presentation should always be taken very, very seriously. Okay, so that's it regarding RPGN and Goodpe disease.